page, which radiopharmaceutical? I'm not sure how big the particles are anymore. I know that they're probably around, I want to say 2 to 6 microns, somewhere around there. Yeah. If they're too small, then they just kind of get lost out into the atmosphere. And if they're too large, they wind up going into the throat, getting swallowed. So all the companies that produce these nebulizers will tell you that their particles are a certain size, but it's pretty close to about the size of a red blood cell that you want it in order for it to go and distribute properly in the lung. I think a lot of people have their patients swallow water before they start doing the imaging. You guys do that? You might want to consider, if the patient can, if the patient's not NPO, you may want them to drink some water just to flush the esophagus of any BTPA. Okay. Number 31, according to the NRC, the geometry test for dose calibrator should be formed in order to check for what? Okay, yeah, remember letter D. Remember how to do a geometry test? You have a known amount of activity in a certain size vial, and then you change the volume without any more activity. So if you have 10 millicuries in it, let's say you have a 60 cc syringe. If I have 1 ml, it should still read 10 millicuries. 2 ml, 10 millicuries. Okay, so in other words, that shouldn't change regardless of what volume I put in there. However, as you get more volume, the detector area changes, so you're not getting all the counts anymore. Remember how to calculate the correction factor. And by the way, what's the allowable limit? 10%. Okay, plus or minus 10%. So, if you ever look at your dose calibrator, some of them may only have a couple of little areas that detect radiation. Some of them may have, a complete circular thing around for your detector area. But in these containers here, do you remember what type of gas it uses? Argon. Okay, argon gas at how many atmospheres? 1. It's about 33 atmospheres. Okay? So the problem that you run into is, let's say that this is your syringe, and with 1 cc, if I have 10, let's see, 1, 5, 10, 15, okay, so I've got 1 cc, I have 10 millicuries in the container. It should read 10 millicuries. So I add another cc of saline, and I keep on adding it. I get to 5 cc's, and it measures 9.8 millicuries. Okay, add some more, and it measures 7.5 millicuries. And I get to 15 cc's, and it measures 5.5 millicuries. Okay, so the problem is the activity hasn't changed, but as the volume gets up to here, for example, more of the activity is going out through the top. It's not being detected by the sides anymore. So the next thing we have to do is develop correction factors for those volumes. Okay? Is anything more than 10%? I'm okay with the 1. What about the 5? Okay, what's my percent error here?
10%.
I'm sorry, it's about 2%, isn't it? Or not? How would I calculate it? Well, remember, it's going to be expected minus actual divided by expected. Okay, so about 2%. Okay, down here we're up to about 25%, aren't we? Okay, so my correction factor is going to be 0.25, or what's it going to be? The best way to get the correction factor is your expected divided by the actual. Okay, so what's that going to be? 10 divided by that? 1.25? Was it? Okay, 1.3. Okay, so that means anytime I have a syringe with 10 millicuries in it, whatever that activity is, I have to multiply it by 1.3. Does that make sense?
So it's expected over actual?
Yeah, that's the actual over measured. That's the quick and dirty way to do it. So, but any reading that you get on that size syringe, if it's more than 10 ml, you have to multiply the correction factor. Normally these things should be published somewhere. And you should have this thing available in your hot lab or next to the dose calibrator or something. I don't see them very often. Okay. And remember, geometry is performed at installation and at repair. Okay, all of the following are considered, let's see where we are here. Yeah, all the following are considered to be examples of personal protective equipment except. Yeah. All it does is tell you that you've got a lethal dose, right? Okay, and this is something you would be using on your well counter on a daily basis, and I think I showed you a well counter that has all these little like fine tuning and high voltage things. A long time ago I brought that well counter in, and it had a what they call a fine scale. It had a large scale thing, 10 volt increments, and then it had what they call a fine scale. Maybe you don't remember that. It was called the gain. It's called the gain button, but it's the amplification on it. And so what happens is you're basically changing the voltage to the photomultiplier tube. Okay? And by doing that, that changes its sensitivity. As you get the, as you're adjusting the voltage, you see that the counts get higher and higher and higher. Then after a certain point they start going down again. Okay? So your idea is to adjust it to where you get the voltage that gives you the maximum number of counts. So that's why the answer here is 520. Okay, that's the peak. So you want to set the scintillator at the peak. Normally we do use 137 cesium as a point source to do this calibration. And what we're actually looking for is every day that I do this, I should have the same voltage. So my peak should always be at the same point. Does that make sense? Okay. When you start having it where it starts changing too much over a period of every day, then you have what they call voltage drift. And so that means you probably have to repair or replace the machine. Okay. So.
What is the allowable drift?
Well, if you start getting, like I said, if it should be like maybe 1 or 2, or maybe up to 5 volts, so it might be 525 one day and 515 the next day. As long as it stays in that range, you're probably okay. But when all of a sudden, you start having, it's like 500 on one day and 535 on the next day, and when it's jumping all over the place, it means that probably your high voltage supply is bad, or the crystal on the inside of the well counter is bad. So most of the time it's the high voltage source that's bad. Okay. But again, what you're looking for is the highest number there, and that's your peak. This is a really good question here. It says, at what time is the last time that you can inject a patient and not exceed 150,000 particles and give 4 millicuries. Okay. Have you figured these out? Have you guys gone through this? What do you need to know to quickly solve this problem?
How many
Half-life.
particles per ml?
Yeah, remember the particles per ml is not going to change, correct? So if you have 350, now let's see. Okay, it doesn't tell us how many ml we originally started with. So if we had, how many particles would there be at 8 a.m.?
250. Particles don't change either, do they?
No.
No, the particles aren't going to change. So you have 13.3 millicuries, 350,000 particles per ml. The main thing you got to determine is what.
How many hours would we get 4 millicurie?
Yeah. How many ml are you going to have? Let's see here. Okay, so the first thing you would have is 4 millicuries, and we're going to use our equation here to determine the number of ml. Okay, so here's dose, strength. Strength is the millicuries per ml, and then volume. Okay, so we want to know the volume, or what volume is going to give us 150,000 particles, right?
Yes.
Okay, so we have 4 millicuries, and we have 13.3 here. So 4 into 13.3 is going to be what? How many ml?
Divide?
Yeah. Normally if you cover up the volume here, so I have 4 divided by 13.3.
0.3.
Okay, so 0.3 ml at 8 a.m. times, we have 350 particles per ml. Okay, so 0.3 times that is going to be roughly about, what, 10,000 particles?
105. 0.3 times that?
Yeah.
105.26.
Okay. So now we're just going to basically have to see how many ml it's going to take at each one of those times to get the same activity. Okay. So the next choice we have, at 9 a.m., we've decayed down by a factor of 0.891, right? So there's a couple ways you can do that.
11.85.
So at 9 a.m. it's 1.2.
If you take 0.3 and divide it by 0.891, what do you get? 0.33. Okay, so in 1 hour at 9 a.m., you're going to need 0.33 ml, or roughly about 0.3. Okay, multiply that times 350, and how many particles is that?
117.845.
Okay, and then the next time is 11 a.m. or 10 a.m. or 10 a.m. Okay, 10 a.m. and 0.33 divided by 0.891 should be about 0.38 something.
Yeah, 37.
Okay, so 0.37 times 350,000. I think we're still okay there.
130.
How many?
130,000.
Okay, So now at 11 a.m., again, divide that by 0.33, you know, you get 0.43 ml, right? Times 350,000.
145.
Okay, I think that's going to be the last time factor that you could use and keep it below 150,000 counts. I don't know, there's not a real simple way to do this question. Okay, but basically you have to ensure that you don't exceed, I think it's about 0.45 ml. Because the other way you could do it, to calculate the actual ml that you need, if you had 150 particles per ml, and you divide it by 350,000, make that particles, I'm sorry. Okay, this will tell you the maximum volume that you can inject. Okay, it should be like about 0.45. Is that what you get?
0.43.
Okay, 0.43? Okay. So, as long as you keep doing this calculation down here, and you get 0.43 or less, okay, once you exceed 0.43, then you're injecting more than 150,000 particles. Does that make sense? This is probably the best way to start out, is find out what the maximum volume is that you can inject, and then just go through and see at what time you're going to get that volume. So 11 a.m. is the answer on this.
11 a.m. I'm getting 150.
Yeah.
50,500.
It's close enough.
Yeah. Well, I mean, if you did it like pure science-wise and carried it out to a significant number of figures, you probably. But so basically, at 11 a.m. is when you would. That's probably the last opportunity that you would have to inject 150,000 particles. So far, so good. I'll keep that one in mind there. Okay. Okay, 35. Gallbladder ejection fractions. How many of you guys do that? Okay, I think everybody's done it. One of the things you might also want to keep in mind is what is the normal gallbladder ejection fractions?
35.
Yeah, about 35%. So, question here is calculate the ejection fraction. Now, somebody else might carry that question on a little bit further and ask you, is that normal or abnormal? So, they give you a percentage and they say that is normal. Okay, so on question number 35, what did you get? Remember, expected, or max minus min divided by max times 100. So 63,800 minus 37,200 divided by 63,800 times that, so you get 42%. Did you get that? Makes you feel good when you get the right answer, doesn't it? But you got to be real careful. Some people would just take the 37,200 divided by 63,80. You might get close. Yeah, it's not going to be the right answer though. But if you did it that way, you notice that there's an answer for it. Okay? So please keep that in mind. You got it? You see what I'm saying? So 63,800 minus 37,200, and then divide that by 63,800. Because if you just do it the other way, then you're going to get that with the wrong answer, and then I'll see you here next year. Okay. to reduce septal penetration of I-131 whole body. This one's, I would be very careful with this one. Fortunately, they don't give you a medium energy choice here. So the correct answer is letter E. But the thing is that, you know, typically low energy is usually 200 keV or less. Medium is 200 to 400. And then anything above 400 is considered high energy. In our collimators that we have now, you don't even get a high energy. We just call it low and medium energy. Right?
No,
Low and
it's
high.
high.
Oh, they call it low and high?
We have a low, medium, and a high energy collimators.
Well, yeah, typically the high energy ones were for things above 400 keV. We actually used to image certain radiopharmaceuticals like, I want to say like 198 mercury. We'd use mercury imaging for renal studies and things like that, and those were 1.1 MeV. Okay. But we had very thick crystals too that we would use. We wouldn't use them on a gamma cam. We had rectilinear scanners. Okay, so anyway, next one. Technologists must administer 8 millicuries of nebuprofenin at 11 a.m. Based on the vial information, what volume should be administered? Be careful these questions here, because anytime they have something that says the vial is expired, take a look at that, you know, because sometimes they'll have a calibration time where it expires. Has this vial expired?
No.
No, so you're still good. Okay, so what's your volume? Mr. Singh, what volume are you going to administer to this patient on question 37? Huh?
I think D 1.1 ml.
What did you get, Ashley? Think it's good? You trust him? You bet your life on him? Okay, the correct answer is letter D. You want me to go through and show you how you get it?
Is it letter D?
Yes.
It says 11.8 millicurie per ml.
Yeah. That's for 7, and then we come up with 0.68.
Yeah, but the thing that, okay, what your question,
Expiration, look at the expiration.
okay, let's see. Okay, the important thing is this, okay, it's 7 a.m. The concentration, you don't even really need to worry about this, because if you divide 8.5 into that, you're going to get this. Okay, so the thing is, you've got 11.8 millicuries per ml. And we're going to use our, we don't use that one, the right one. Okay, so we have 11.8 millicuries per ml. And we're going to use our activity is equal to e to the minus decay constant time. Okay, so we've got 11 o'clock, which is 4 hours, right? Okay, so 11.8 times e to the minus 0.1155 times 4 hours. This is like 4.2 something minus 4.6 or something.
4.6.
Okay, so e to the minus 4.6, or the other way you could do it is just, you know, take 11.8 and multiply it times 0.891 times 0.891 times 0.891 times 0.891. Okay, that's the other way you can do it. Okay, but in this case here, we have 4.6, e to the minus 4.6 is what? Should be about like 40% or 50%.
That minus 630.
Let me see. Okay, it's about 63% left. I'm just going to go to the calculator here. Make sure, you guys, I don't know 100% if they're going to let you take your calculators in. So please be prepared for whatever calculator they're going to give you. But we had 0.1155 times 4 hours, so 0.462. Remember, if it's pre-calibration or post-calibration, that will determine whether you use a positive or negative number. This is post-calibration, so we make it a minus. Okay, and then we go to the natural log over here, and since we want e to the x, remember that the reciprocal of the natural log is e to the x. So I have to come up here and then hit that. So there's 63%. Okay, so we have 11.8 times 0.63, because that's how much percentage is left. So roughly we have about, what is it, 7.4 millicuries per ml at 11 a.m. We've gotten the same number over here too. Okay, so now we take our, let's see, it was 4 millicuries, 8 millicuries. Okay, 8 millicuries divided by 7.4 millicuries per ml, and that's how we got our 1.1 ml. Okay. You need to be able to do these very quickly, though. Remember, you're going to only have about 35 seconds per question. Okay. So go through the ones that you know as quickly as you can, and then come back to the ones that you're not sure of. Okay.
When we finish taking the test, does it give us a preliminary score, or do we have to sit there and bite our nails until?
Well, the ARRT, I remember I went through that last week, because you're going to do all the questions. You're not going to. And the only way you're not going to do the questions.
No, he's asking you after we submit to get a
Oh.
score
Does
right
it give you like a score right away, or do you have to sit there and
Is it like X-ray?
piss your pants for a few weeks?
The NMTCD, yeah, both of them will tell you whether you pass or not,
Okay.
or they should.
Right away.
Yeah. Yeah, just that you have, like I said, if the questions stop as you're going through the NMTCD before you get to the end, then you probably passed. Either that or your answers were so terrible they just said, no way, this person's working with radioactive material. But ARRT, you will be doing that because, like I said, they use those questions to determine whether or not they're going to be using them on future tests. Because, you know, they actually count the number of times that question appears on an exam. And they know that people talk, and they know that people are going to cheat and not, you know, be ethical about it. I, on the other hand, I just go look at the test myself and no, I don't do that. The thing is that these questions that you're seeing are very, very close to what you can expect for your boards. This is probably the best one. The people that wrote these are very high up on the SNM, ARRT, and NMTCD food chain. So they get to do a lot of this stuff. Okay. Next one. Parathyroid adenomas will concentrate which of the following radiopharmaceuticals?
Systemating.
Okay. So on question number 38, says to MIDI. What is the other radiopharmaceutical that a parathyroid adenoma will concentrate? Not protectanate.
But I-123 is for uptake,
Well, parathyroid adenomas will take up iodine.
right? So
That
thallium.
Thallium. Okay. Yeah, they used to, if you run into a pinch, you can always do a dual isotope study with thallium and protectanate. Do the thallium first. Why do you do thallium first?
So we could go in.
It's a lower energy. Yeah, whenever you guys are doing dual radionuclide studies, it's always better to do the lower energy radionuclide first, because then you don't have the downscatter. Okay, the next one. Performing a diuretic readiogram on a patient with possible left kidney obstruction. In processing the curves, it's noted that the left kidney showed a delay in reaching the peak activity with normal emptying after the administration of Lasix. This would be an example of what? So it's abnormal building up, you give Lasix and it becomes normal. So what are you dealing with? Is it obstructed?
No,
Okay,
it's
so,
normal function.
Is it normally functioning if it keeps building up without excreting? No. Okay. It's not a mechanical obstruction. Is it reflux?
Yeah.
Cynthia says it's reflux, so she's out at letter C.
Well, just keep that.
Andy, what do you think it is? What do we do Lasix for?
Transplant.
Differentiate between a dilated ureter and obstructed.
Yeah, it's the difference to dilated versus mechanical obstruction. So it's not transplanted, so it's not obstructed, dilated ureter. So letter D is the correct answer. Now, when I send you guys these new tests and everything, I do kind of expect you to take a look at them. Especially now with only a few weeks left and you guys getting ready to take your boards. Studying for these tests is a lot better before you take the test rather than failing and studying after, if you know what I mean. Okay, here's your next study. Patient's end-diastolic is 180 ml, and systole is 70 ml, output is 5.5, pulse rate 50 beats per minute. What's the ejection fraction? What's the formula? What information do you need on here? Do you need the heart rate?
Stroke volume.
Do you need the stroke volume?
Yeah, that's how you
Yeah.
calculate the ejection fraction.
Okay, so you don't need that there's 5.5 liters. You don't need the pulse rate. So basically it's going to be end diastole minus end systole divided by end diastole, right? 61%. So ED minus ES divided by ED times 100. Is that okay? The patient need a heart transplant? Yeah, 60% is good actually. It's not bad. You should know normal values for this because the other question that somebody like, especially me, when I write questions for the ARRT or the NMTCB, my next question would be, is it normal, abnormal? Okay, what do you do with this patient? I would actually ask, is it within a normal range?
We'll be a doctor already.
Well, you guys already are. You guys get out of here and
What's
get...
the cutoff like they put in home?
Well, if you have a really high ejection fraction, then either your regions of interest are incorrect, you either put the wrong regions of interest, or the patient may have regurgitation. If they have like mitral valve, mitral valve prolapse or mitral valve insufficiency, things like that. So in other words, a really high ejection fraction means either the computer selected the wrong region of interest, because sometimes it'll select the superior vena cava, or your regions of interest are wrong. In other words, if you make the background too small or too tight, things like that. And those are some of the other factors that you need to look at. In that, I'm trying to remember if they have it in that other booklet that I gave you from the University of Arkansas. It tells you what the effect of improper regions of interest is. Like if you make it too big or too small. You know, you just if you do the calculations, you know, let's say that you had a patient that had a certain, you know, volume, and then if you increase the region of interest for the background, how would that affect it? Or if you decrease it? Okay. So in other words, you know, most of the time, if you make it too small, it makes it artificially high. If the background isn't large enough. A lot of times when you guys draw regions of interest, they do what they call normalization. So in other words, if you have like 500 pixels for the heart, then you should have about 500 pixels for the background. There's even a thing in the math book that describes how you do that. Okay. Not that they're not going to probably do that to you on your board exams because there just isn't enough time. And when you're doing a board exam, you don't, like I said, 35 seconds per question is all you get. So anyway, so in this case here, just remember that you can affect the outcome of your results by not having the proper region of interest or looking at what the computer selects. It really, really frustrates me and makes me upset when I go into a hospital and I see some technologists put this thing on autopilot and they don't really pay attention to what's going on. Now, if you're getting paid $35, $40 an hour, you better watch that computer select regions of interest and do the calculations. Okay. You also better make sure that when you're, you know, setting everything up, that you have a good separation of the right and left ventricle. Okay. You know, people that don't take the time to get a good separation of the right and left ventricle. And typically, which projection of a MUGA study would give you the best separation? Okay, LAO. Yeah, so somewhere between 30 to 45 degrees LAO, depending upon the body habitus.
10 degrees,
And yeah, cognitive tilt. Yeah, so you guys are aware of that. Okay. You don't have a good separation, you're not going to get good ejection fraction.
My hospital, they don't do the collar tilt, but it still come out the same.
Well, I'm just telling you, sometimes you can get a better separation. Yeah, you can get a separation.
Most of the patients work chunkier, huh? Is it chunkier patients that works better with?
Yeah, probably, because if you remember when you're obese, everything is kind of pushed up and more horizontal. Okay, it's like with the stomach. If you're, you know, taking a picture of the stomach for like a gastric emptying, the thinner the patient is, the longer and the further down in the abdomen it goes. Fat people, the abdomen is pushed up and it's more horizontal. Okay, same thing with your other organs. So that's why you need to look at the picture and make sure that you got a good separation. Okay, next one. Areas of prolonged retention in the lung is associated with what? What is it? Yeah, remember if it doesn't wash out, okay, we have the patient breathe in. That'll tell us if there's any areas that are obstructed. Then we do an equilibrium. We allow the gas to go all through the lung. And then when they try to exhale it, if it stays in there, then that's your area of COPD. So obstructive lung disease is the answer, number 41. Number 42, circular ring artifacts, often called bullseye artifacts, are the result of. You probably haven't seen those. Let me see if I can find them. I did have, in my Christian book that was stolen, they had a beautiful picture of it. I don't think they have it in our current one.
Would it be A?
It's the non-uniformity, so on number 42 the answer is A. That's the reason why you have to do those, well, actually when you do uniformity correction, there's actually two aspects of it. One, you take a picture to show that it is uniform, but then you have also what they call a uniformity correction program, where it actually requires a new flood or new set of numbers to correct.
And if some PM2s are a little darker or lighter, it balances them all out.
Yeah, and that's what you have to be careful of. You have to take a picture with the correction on and a correction off. Because with the correction off, you're seeing what the true crystal looks like. When you put the correction on, it will actually compensate and fill that area in.
So even if there was an error, it might compensate for it?
Yeah. That's the problem with it. But it looks like a bullseye. And normally on your board exams, they do have a picture of it. After you guys get back from lunch, I'll show you, I'll see if I can find one. It's called a bullseye or ring artifact. And it's, if you remember, what is the allowable non-uniformity that we...
15%.
No.
5%.
Okay, when you do a daily flood, we have one value for the amount of non-uniformity that we accept.
3%.
When you do SPECT, it's another number. So for your daily floods, what's the allowable percent error that we allow?
5%.
5%. Yeah, plus or minus 5%. Remember, that's two standard deviations.
That's in the central, right? In the central part? Because it's different for the edge, right, or something? I forgot.
No. It's, well, I mean, you have, when you do the, well, you're allowed plus or minus 5%. So if you looked at all the number of counts and all the pixels, you know, it's going to be like maybe 2,500 plus or minus 5%. When we do the SPECT, and the only time you're going to see this is on a SPECT study. What's our allowable limit of uniformity? 1%. Yeah, remember that's why you do 5 million counts or 3 to 5 million counts on your daily flood. When you do a weekly or, I don't know, some places I think do monthly tomographic floods. How many counts do we have to get?
30 million.
Okay. Well, it depends on the matrix that you use. If you use a 64 by 64 matrix,
Yeah, in the last 30 million.
30 million. Yeah, if you use 128 by 128, it's 120 million. Okay, that's why, you know, it takes all weekend normally to do it. You start the flood on Friday when you go home, and you hope it's done Monday when you come back in. Now, it's usually maybe overnight. Okay. Okay, what would be the expected test results if some of the radiopharmaceutical was infiltrated during an injection of I-125 for plasma determination? You will see, this is the same type of a question if you don't have your background set properly. How would that affect your ejection fraction?
Would be enormously low.
No. Let me kind of give you an idea of how that works, then I'll let you go to lunch. Okay, the way that we do this, you're going to see this thing, C1 V1 equals C2 V2. Okay, this is what they call the dilution formula. You use it for, this is actually how nuclear medicine got its start. So basically, you have a standard. Okay, you put a known amount of activity in here. Let's say that you have 100 ml. You put in 10 microcuries. And when you take out 1 ml, let's say you get 1,000 counts per ml. Okay, if I inject the same amount of activity into the patient, and I withdraw blood 20 minutes later from the other side, you don't want to withdraw blood from the same side that you injected. So I take out 1 ml from the patient. Okay, by plugging in, I count it. Let's say that I get 10 counts. Okay, when we set up our thing here, okay, we're going to find that 10 goes into 1,000 100 times. So that means that the patient has 100 ml. If we go back to our formula up here, okay, so we have 10 counts in our unknown volume, and we had 1,000 counts in 1 ml. Okay, so these two things should be equal to each other, so long as you have what they call a closed system. So that means that the patient has 100 ml of blood. Now, what would happen if I infiltrated? Let's say I infiltrated half the dose.
That's going to be in the bloodstream and stuff.
Right, so what's going to happen is the counts in the blood are going to be lower. So what happens now? Now I've got 200 ml because half of my counts, when I divide that into the 1,000. So typically, anytime you infiltrate a dose, especially for this type of a study, it's going to be erroneously high. Okay, the same thing as if you were looking at, volumes or ejection fractions and background. Okay, so on that happy note, I'm going to be sending you some problems for this too, so don't panic. Actually, you should panic when you get them, but until I send them to you, don't panic. Okay, so why don't you get some lunch? See you back here at 2:30? I mean 12:30?
Yes, 2:30.
See you back at 2:30, and we just go home?
Yes.